evening, everybody. I can see we have got some people with us. I'm being joined tonight by Dr. Raul Oliveras from Barcelona Ivf. Welcome.
Good evening.
It's great to have you here tonight. As people will know from having registered, the topic is IVF in your later 30s and treatment options. So I'm Eloise, and I am the founder and editor of Fertility Help Hub, which is a lifestyle fertility platform which offers an app, daily content, expert resources and tips, everything that I wish that I had personally had when I was going through IVF abroad to have my sperm donor conceived children. And I would like to welcome Dr. Raul Oliveras, who is the medical director of Barcelona Ivf. Please, can you tell us a little bit about yourself?
Well, as it is said in the slide, I'm very vocational doctor. So since I remember, this is what I wanted to do. Along with 4 more partners, I think that we have created a really particular project in which we, apart from trying to have the best possible results, really strong focus on treating patients in a very individualized and personalized way, which is something that's very important because of the difficulties that patients go through when this kind of treatment. And in these last years, well, I think that we've been working a lot. Probably 50% of our patients are coming from abroad. Unfortunately, nowadays, not so many British couples because of the situation. We have to still work a lot with French and Italian couples. We offer all types of treatments. The only treatments that are not legal in Spain and then can be offered are gender selection and surrogacy, but any other options like IVF, egg donation, PGS, single parents, lesbian couples can be treated in our clinic, and we're very happy to help everyone.
Thank you. And we've got some really great questions that have come in. And so please tell us a little bit more about Barcelona IVF in terms of how it works for patients who are coming abroad for treatment and how they can do that with COVID and things hopefully easing up soon.
We opened the clinic 10 years ago. We are currently doing like between 1,500 and to 2,000 cycles per year, transfers, some of them IVF, 50 IVF and 50% egg donation. This is our clinic, which is an old planetarium. We offer to all our patients first free consultation, either via Skype. We have a 24-hour service, 7 days a week. We have a 7 days lab because we do transfer on day 5. So that means that if we do the collection on Monday, we transfer on Saturdays. We do not have any waiting list. That's important with regards to the donors, and that's allow us to choose and confirm who is going to be the donor in 7 to 10 days. Patients just need 1 or 2 trips to Barcelona, and they tend to be really short. Everything else is done by email, using the medical assistant. We ship prescriptions. The patients are followed by their gynecologists in their country. And we also take care of all the things involved in the travel. We do a lot of things to try to improve the process in the lab. Whenever we work with an egg donation, we work with fresh eggs. We use the time-lapse technology, which has proved to be very useful when you are selecting the embryos. We combine the morphokinetics, so how the embryo has evolved, how the embryo has done its homework during those 5 days, with the morphology on A5, and then we select which is the embryo that is going to offer. We can do different types of PGS, PGT, so that basically allows us to reduce the time that patients need to have a baby. We have a state-of-the-art laboratory with all the recent technologies, and we very strict workflow to keep the conditions throughout all the process. If you know something about the lab, you see that you probably are aware that it's very important to work in the same conditions throughout, because the oocytes and the embryos are very sensitive to tiny changes. In this sense, time lapse, which are these incubators that have individual places where the embryos are left for 5 days, is very useful, because we don't even have to take them out from the incubator. We can just assess their quality on the computer screen, because this incubator has a small camera that takes a picture every 15 minutes. This is why it's called time lapse, because at the end of the process, we can make a video with all the pictures that have been taken during those days and get information about the kinetics, how the embryo divides. But also it allows us to not disturb the embryos. The embryos are kept under the right conditions during the 5 days. So in my opinion, it probably is much better to have an embryo now in this kind of incubators than even in the tubes or in the uterus. And of course, another important thing is that we usually work with day 5. I mean, I know that especially in older patients, there is kind of a trend of transferring on day 2 or day 3 because first, there are clinics that say that that's better for the embryo, which is something that I really don't agree with. And also because probably they are afraid of not having an embryo transfer. The reality is that the most critical day for the embryos is day 4 to day 5. So if you are transferring on day 3, you may be transferring embryos that are not going to become blastocysts. And then if the patient doesn't get pregnant, you may think that there could be something wrong on the uterus, but really happening is that these embryos get blocked and do not become blastocysts. So taking all the embryos to day 5, passing that critical point of day 4 is very important to know the real quality of the embryos and to avoid recommending unnecessary tests thinking that there could be something wrong on the uterus or in the patient's body when the real problem is that the embryos don't have the quality that they should have. In regards to the results, this is pregnancy rate per cycle, so it's not just a fresh transfer. This means the chances that you have to get pregnant with any of the embryos that have been created after a single egg collection. There is a real big difference depending on the frame of what you get, between the 42 and after the 42, there is a huge drop in the fertility, mainly related to the genetic issues that the oocyte have. And well, we will try to clarify how we can handle that situation. With regards to the egg donation, well, since the eggs are always going to come from young fertile girls, there are no differences related to the age as long as you have a healthy uterus, as long as there is no male factor, the quality of the embryos is always going to be the same and the receptivity is not so impaired with the age as the quality of the eggs is. So that basically means that you can get very similar pregnancy rates if you are 38, 42, or 40, 49.
How much do they differ from your late 30s to your 40s? You touched on egg donation not making a big difference.
Well, as you can see, well, the fertility is supposed to be quite stable until you are 35. And then as a general rule, you can consider that once you are over 35, you may be losing fertility every year. Once you are over 38, you may be losing fertility every 6 months. Once you are over 40, you may be losing fertility every 3 months. And once you are over 42, you may be losing fertility every month.
For, let's say, a 40-year-old or someone in the late 30s, what would be your standard consultation or tests and then protocols and medication?
The protocols are always focused on trying to have a really good stimulation. 1 egg or 2 more eggs may make a really huge difference. We try to work with a drug that is called Elomba. It is comfortable because it's 1 injection that you take and it's going to stimulate you for 7 days. It has a profile which is more similar to how the natural FSH works in the natural cycle.
I'm sure you have a lot of people coming to Spain due to expertise, but also donor. Would you say that a lot of people in their later 30s and 40s come to Spain and see you for this reason?
If according to the result, 1 in 4 egg donation cycles are done in Barcelona, not even in Spain. And this is why probably I would say that 70% of the patients that come to Barcelona are seeking for egg donation. We are seeing a constantly increase in the number of patients that are just looking for IVF. So in terms of how choosing a clinic, I would say that so it's more like a personal feeling or the fact that if you go to a big clinic, you may feel like a number. And if you go to a clinic that is a bit more like me and I am your doctor, I'm going to be your doctor during the whole process and you're going to be discussing everything with me.
I was speaking to a Fertility Help Hub reader today, actually. They're a lesbian couple and they've been having treatment with you and they're delighted and they have frozen embryo that they're desperate to come over and transfer. So they're counting down the days until they can come back and see you again. So if this first treatment doesn't work, is it worth a second attempt?
IVF, it's important for 2 main reasons. The first one is that it is a treatment. We must do our best to make sure that it works and that the patients have a baby. But the second important thing about IVF is that it's going to provide us with a lot of information about things that we do not have other way of knowing. The information that you gather from the first IVF that you do is very, very important because it is not the same if you have a low fertilization rate. It is not the same if you start with a good number of eggs and you end up with just a couple of very poor quality embryos. These are kind of things that are going to it, in quite a few cases, shed some light on the cases, and it's going to give us information on what are the next steps that should be done, considering new tests or just moving forward with another round. And this is why I always insist that it's so important to reach day 5, because if not, we are missing information about the real quality. So that would depend a lot on what has happened during the first IVF. Just whenever you have an IVF, try to make sure that you have everything done so that that information can be later used to decide if it's worth a second attempt or not.
Is the embryoscope, if you could explain what that is, raising probabilities of success?
Embryoscope is a brand. There are different types of time lapse technology, but at least in our hands, one of the relevant things about the embryoscope is that you cannot extrapolate your results to other clinic, because it seems that the kinetics of the embryos, depending on the environment issues, you have to design your own protocols to assess when the embryo is doing the things in the right way.
IVF for single women, I presume that's a similar process for a heterosexual couple with male infertility as well.
Is a bit different depending on each case, because one of the big difference between a single woman and a couple is that the couple has probably been trying to get pregnant and they have not succeeded. So that means that there is a kind of a problem. But when you have a single woman, unless she's 44 or 45, that you can presume that it's going to be an issue. Let's say that you have a 39 years old woman who is trying to conceive, and you need an IVF because they have no partner and she wants to maximize chances. You don't have to assume that there is a problem with the quality of the eggs, and then probably the overall pregnancy rates are higher. And the way you must approach to that patient in terms of the test that you should do or the protocols you should work with is going to be a bit different. The problem is that there are some countries, like in Italy or in France, that where this woman cannot have a treatment, and this is why they came to Spain.
Sorry, when I meant heterosexual couples, I meant those who are using donor sperm because the issue is, lack of sperm, azoospermia, or male infertility. And so I guess that leads on to the next question, doesn't it? The different options for people later in their 30s and 40s.
Well, this is one of these kind of things that could be different depending on whether you are a single or you have been trying to conceive. If you are 38, if you have normal tubes and you have never tried to conceive, why not trying with an IUI, which is a very easy treatment in which is just going to get some sperm insert into your uterus, and then everything is going to be natural. Of course, if you are 38 and you've been trying with a partner for a couple of years, probably, and you have a regular cycles and the sperm is okay, the IUI are not going to add that much to what you can already get at home. So that may probably is going to make you think that probably IVF is much better. Of course, in any case, in the end, basically you need to individualize each treatment and decide. With regards to the ICSI, which is a different way of inseminating the egg, you can do a conventional IVF in which you just leave the egg 100,000 sperm and then see if any of them succeed, or you just choose a sperm and inject that sperm into the egg. We do ICSI in 100% of our cycles, because if you do conventional IVF, you may have an expected low fertilization rates in patients that have no issue, and then in a second cycle you are going to offer ICSI. So we think that it's not really necessary to waste one cycle just to add the ICSI. And we do ICSI even when we have a sperm donor and an egg donor, because it guarantees that your fertilization rate is going to be always above an 80% if everything is okay and if there is no issues with the sperm.
Sorry, just going back to IUI, how does that work in terms of people coming to Barcelona? If they're coming abroad?
That's very similar to the IVF. The differences are the protocols. They have a protocol that we decide based on their ovarian reserve and on their age. And then we send the prescriptions, they get the drugs in the countries, they contact us on day one of the period, they're telling us, I want to start. And then we tell them when they have to book the first scan, and then they send us the scan report. And based on that, we decide how they must continue until there is 1 or 2 follicles around 17, 18 millimeters. Then we trigger ovulation, and then is when they come to Barcelona. They just come the day before the IUI. We do the IUI and just rest for 10 minutes, and 3-4 hours later they were at the airport taking the flight back to their home, because basically there's nothing else that you should do. It's not like an embryo transfer, so you can't fly back on the same day. So 2 nights maximum to Barcelona if you want to be here the day before the IUI and fly back the next day of the IUI.
Someone just raised their hand, so if you want to speak or just drop a question in the Q&A chat box, please do. I'm going to get to those shortly. You're used to working with very anxious patients who will have done a lot of Googling and probably self-diagnosed their statistics like I did. What would you say for people who have made their own conclusions about statistics?
I would say that there are only one type of a statistic that is really useful for patients, which is the chances of getting pregnant, because there are some tricky statistics like the pregnancy rate per embryo transfer that could be really good. But if it's going to be really difficult for you to reach the embryo transfer because you don't have eggs or the quality of these eggs may not be good, well, what you want to know is what are my chances of ending up with a pregnancy, with a baby, if I start this process, if I start my IVF or if I start my IUI. This is why we talk about statistics, like I've said before, pregnancy per cycle started. And that's the only one, because it's going to give you a real vision of what you can expect from that treatment. My advice is to ask for pregnancy rate or live birth per cycle started, because that's what is going to really let you know what you can expect from that treatment.
And for someone with blocked fluid, blocked tubes or fluid in the tubes, what are the chances of natural conception and via IVF over 38?
Well, with regards to this kind of abnormality, which is usually called hydrosalpinx, which means that there is liquid inside of the tubes, there is a high risk that this liquid may just go back to the cavity, creating an environment that is not going to be the best one for the embryos. The embryos need a certain degree of inflammation to implant. If this inflammation is really high, and this is something that this problem can lead to a really high degree of inflammation because of the toxicity that the liquid has, this may dramatically reduce the chances of success. Even, of course, natural conception is going to be really difficult because the tubes are going to be ill, are going to be impaired. But even if you do IVF, that you are supposed to be to avoid the tubes just placing the embryos inside, you may get a really adverse environment. This is why we usually recommend that whenever we see fluid in the tube, to go through surgery and remove the tubes, just to make sure that there is not going to be something wrong in the endometrium.
Will improve their egg quality.
I think that the main problem that we have right now, because there are so many things that are supposed to improve your egg quality, from protocols, drugs, DHA, acupuncture, the holistic approach. There are many things that when you read, you see it's supposed to increase or improve the quality of the eggs. We rarely know when the egg is going to be good. I think that the main problem that we have right now is that we don't have tests to identify these good eggs, and then it's going to be difficult to know in which patients what kind of treatment is going to help to improve the quality.
So you might suggest multiple retrievals, for example.
In some cases, it could be a good option. And of course, vitrification, which is now widely available for those patients that do not still have problems, but they might be on their late 30s, 35, 36, 37. They have no partner or they have no plans to get pregnant shortly. So freezing the eggs it could be a really good option nowadays, because then, well, you may not need them because you may get pregnant after when you are 38 or 39 and you have your partner, or you may try an IVF when you are 40 and succeed. But if the time goes by and you became 41, 42, and then you suddenly realize that the eggs are no longer valid and you have some frozen eggs, well, that's a good way, because it's going to avoid you from needing an egg donation. So that's something that we are also promoting a lot, because we have been telling women for many years, take the pill, take anti-contraception, that now they seem like they can just delay the pregnancy until they are 40, and they reach their 40s, they are healthy, awesome, they go to the gym, they look great. But unfortunately, the eggs have their own way. This is not something that is going to change in one generation. So I would say, how can you improve the egg quality? freeze them when you are young enough.
With a diminished ovarian reserve and a low AMH level, what kind of level would you normally suggest egg donation?
Well, it's more a combination of age and ovarian reserve. I mean, one of the main problems that we have with the ovarian reserve is that sometimes we don't know if the patient has always had a low ovarian reserve. Could not be a problem if you are 25 and you have an AMH that is zero point 0.4, which is quite low. Uh, I know that sometimes it could be tricky because in UK, they usually work with the different units instead of nanograms per milligram, which is what we work, and we consider the normal cutoff as 1. And in UK, they usually, or in other countries, in United States, work with picomoles per liter, and then the cutoff point is about 6.2. So I'm used to talk about AMH using my nanogram, so it's going to be 1. But when I say 1, if you are working with picomoles, think about 6. The thing is that if you have a really low ovarian reserve and you are 25, you may produce 1 or 2 eggs, which is not that much, but they could be of wonderful quality, and you may be able to get pregnant on your own because you just need 1 egg per month. Probably you couldn't be an egg donor. If you are stimulated, you are not going to produce a lot, but the quality is going to be fine. If you are 43 and you have a low ovarian reserve, well, it is not that you cannot get pregnant using IVF. The main problem I see in these cases is that if you cannot produce a lot of eggs or a good amount of eggs, the chances that IVF is going to offer you, if everything else is normal, if the tubes are patent, if the uterus is okay, if there is no male factor, are going to be very similar to those that you have on your own at home. So in these cases, to me, is a waste of time and money trying IVF because you are going to pass from a 1% that you may have at home for up to a 2% that you can get from an IVF. Someone may consider that that's a good because you are doubling your chances, but in absolute terms is a very poor improvement. So in these cases, I would probably recommend egg donation.
And lastly, before we move on to questions from tonight, any additional tests required for women in their later 30s or 40s?
I would say that the main issue is to work out the ovarian reserve. So you can either do an AMH, you can either have an antral follicle count, doing a scan on the first 3 to 5 days of your cycle and counting all those small follicles that you have, because they are going to potentially let you know how many follicles can you produce. Remember that AMH and antral follicle count are related just to the amount of eggs, not to the quality of the eggs. Another important thing in these patients, especially when they are over 38, is the implantation failure. And the main thing is that I see so many patients, unfortunately, probably there is a bias in the pool of patients that I see, but I see patients that are 42, 43, that they have had like 2-3 transfers of day 2 or day 3 embryos without any kind of genetic testing, without knowing if these embryos could become blastocysts. And they go through an incredible amount of tests to immunology, implantation, hysteroscopy, blood tests, because they think that there is something wrong with the body. And the main problem is that the quality of the embryos is not that good. And transferring a good day 2 or day 3 embryo does not mean at all that that embryo is good. I would say that probably more than 80% of the implantation failures are due to the embryo quality, despite they may look great in terms of morphology, rather than to endometrial issues, rather than to adenomyosis, rather than to chronic endometritis, antiphospholipid syndrome. That's really very, very important. Try to invest, as I've said, the information you gather from your IVF is going to be very useful, and especially if you can really know the quality of the embryos that you are producing.
Some clinics administer both intra-lipid infusions as well as, this person has heard from an IVF specialist in the UK, claims that these medications contradict one another and shouldn't be taken together.
They are different drugs. In fact, they have nothing to do. Intra-lipid infusions are theoretically given to correct an immunological problem. The decapeptyl is given to downregulate the ovaries. The idea is that when you use the decapeptyl, you are going to be in a kind of a pharmacological menopause, so that's going to allow us to prepare the endometrium or downregulate the ovaries before we start the stimulation. And the intralipid infusions are just given to correct a theoretical immunological problem because it's soja proteins that are supposed to cause immunosuppression.
Linda has said, all mine and my partner's tests have come back good. I ovulate and have regular periods. I'm 40 years old, so I know how I have to pay. But the NHS said to go straight to IVF, but private clinics said try Clomid first. Would it be good to try Clomid first?
When you are 40, you may be losing fertility every 3 months. There are another important thing for how long have you been trying to conceive. It is not the same if you've been trying for 3 years or for 6 months. Then if you have been trying for 6 months, well, you can invest 2-3 months with the Clomid to see if this is, the Clomid is another way of stimulating the ovaries, and then have a sex with your partner and see if you can get pregnant. But if you've been trying for 3 years, Clomid is not going to add anything to you. I would probably recommend IVF as soon as possible because what you can get now could be different from what you can get, for example, after summer.
I have been diagnosed with unexplained infertility and have been doing IVF for 3 years. I always get good embryo numbers on day 5 and mostly get pregnant. However, I've had 4 miscarriages before 7 weeks. We are saving at present, but feel overwhelmed. What would you advise for a patient like me? Are there tests that you would recommend?
I'm going to assume you are over 38 because the approach would be very different if you were, for example, 32 and you've had 4 miscarriages, which is very unusual. So that would take us to see if there is anything wrong on the male side or things like that. So one of the things when we are dealing with recurrent miscarriages, 80% of the cases are due to chromosomical issues. The first thing that I would consider is see if you have been tested for this kind of chromosomical problems, having a karyotype done, which is a blood test that is going to confirm that your chromosomes are normal. That would be my first step. And then if you manage to produce a lot of good embryos, then I would consider PGS in your case, just to see if those embryos that look great are also genetically normal. Then once you have done the PGS, if you see that the figures in terms of normal embryos are really good, and then you are pretty sure that the genetics is not the problem, before transferring these embryos, you may consider other tests to assess problems like endometritis, like antiphospholipid syndrome, thrombophilia. In your case, my approach would be a PGS, especially if you produce a good number of blastocysts. And then with that information, we would decide if it's enough to understand your whole case and then proceed with the transfer, or if we think that the PGS is not giving us an answer, consider other tests to assess if there is anything wrong on your side.
Is the chromosome test essential for successful implantation at age 39?
I wouldn't say essential. I would say that depends on each case. We are quite fond of PGS and we are quite happy with the results that we have. But we also, because of our way of working, we try to recommend PGS when we think that it's going to be really useful, you know, and this is something that we do in different aspects. So depends on your case, depends on how long have you been trying to get pregnant, depend on how many embryos, because if you are 39 and you have 2 blastocysts, because that's all you produce, it's worth to check the quality in terms of genetics. Well, the PGS is not going to let us modify the chromosomes. It's not going to let us remove 1 chromosome. So probably it would be worth to transfer 2, and if any of them is normal, it would implant. It, at least in your first attempt. If we are transferring embryos and you don't get pregnant, then we may consider PGS. If, for example, you have, as I've said before, 8 blastocysts, well, probably then I would consider PGS, because if only 3 or 4 of these 8 blastocysts are going to be normal, you are going to save a lot of time and a lot of money, because you are not going to go through unnecessary transfers that may end up in negatives or miscarriages. Very difficult to say in 100% of cases. I would prefer to, if you were 44, yes, definitely, because at 44, only 1% of the eggs are going to be of good quality. But at 39, probably like 30% of the embryos could be genetically normal, 25 to 30, 1 in 3, 1 in 4. So depending on the quality and the number of embryos that you have.
Preparing your endometrium before transfer, any advice for holistic support, such as supplements or an endometrium scratch or exercise or anything else that may help?
The healthier your life is, the better it's going to be for that. So you have a good diet, trying to avoid pro-inflammatory diets or to avoid sugar, trans fats, that's something that is going to help because it's going to reduce the inflammation, and this may make things really easier for the embryos. If you do acupuncture, if you do the right amount of exercise. And with regards to the endometrium, it's quite controversial. The initial big studies suggested that in cases of implantation failure, so that means patients who have already had 2 or 3 transfers, negative transfers, could improve the live birth. But there are also a lot of evidence that if you use it in all patients, it does not work at all. And in some studies, it has proved to even get poorer results because with the endometrium scratching, you are trying to increase the inflammation by activating some genes. But if this inflammation is already good, you may be pushing it excessively to an excessive high level, which could be detrimental for the embryos.
Mm-hmm.
So try to use these kind of things only when they are really indicated.
In terms of travel, what checks would be required before egg transfer? How does that work for a UK patient? And will the UK clinic send you the information?
We usually basically rely on the patients because they are the ones who go to the clinic. We don't force them. We have some places where they can go if they just need some support, where they can do scans on weekends and things like that. But usually are patients that go to the doctors, they get the reports, they just take a picture or scan that report and send it to us.
And do you
So
have a coordinator who works with people to say what tests they need and what they need to have when, etc.?
the coordinator are the doctors, so we decide which are the tests. What they have is a kind of a medical assistant that whenever that are easy to reach than us, the medical assistant is going to follow you through the process, is going to make you the prescriptions, is going to tell you where you can buy the drugs, because we, especially in UK, we work with a lot of online pharmacies, so you can use our prescriptions. You don't need to go to your GP to get them done.
Someone's asked, can I fly after transfer? How long is recommended to stay in Spain for egg transfer?
If you want to fly back on the same day in the evening or the next day, that's fine.
Is it possible to do multiple rounds to freeze embryos for patients with diminished ovarian reserve and low AMH?
Yes, it could be. Sometimes this could be because of many different reasons. I sometimes have patients that they are 38, 39. They are planning to have more than one children, and they think, okay, if I do my IVF and I get pregnant and I have no frozen embryos, and then I want to come back, and when I'm 40, I may have it's going to be really much more difficult. So they prefer to go through different rounds when they are 38, 39, have some frozen embryos left, and then keep transferring. And if they need, they want to have a second child, they already have those frozen embryos. In cases in which you want to do, for example, a PGS, as I've said before, if you have 1 or 2 embryos, it could be worth just to transfer them, keep your fingers crossed and see what happens. But if you really want to test them and try to maximize your chances of getting one normal, well, then you can go through 1, 2, 3, 4 rounds. And then once you have 6 or 7 embryos, then carry out a single PGS in all the embryos. You are not going to do a PGS in every cycle, just at the end of the process. And then the chances that you may end up with 1 embryo for transferring are going to be higher. The only thing that I recommend when patients want to go through more than 1 round is just to try to have the second round right after the first one. The reason is that sometimes the first stimulation may help to recruit more follicles that are going to be ready to be recruited in your second stimulation. If you make a break, you may lose this effect.
After a retrieval, can you freeze some eggs as eggs and some as embryos?
That could be a good option in certain cases. Of course, if you have very few, I wouldn't recommend maximizing the chances trying to work with all your embryos. For example, we have cases of patients who have a severe male factor, and they are afraid that creating embryos with the semen of her partner may lead to poor quality embryos. And they say, okay, can I just inseminate half of the eggs with my sperm, with the sperm of my partner, and freeze the other ones in case I need a sperm donor because this cycle does not work? Well, I don't think that is a good option, because if you really want to have children with your partner, if there is a severe male factor, there could be a risk that you may not end up with a lot of embryos. And if you reduce the number of eggs that you use, the chances are going to be even lower. So Of course, if you are lucky enough to produce 30 eggs, yes, you can inseminate 15 or 18 with your sperm, with a partner of your sperm, freeze the remaining 15. And if you see that this cycle is not working and you want to inseminate the other ones with a sperm donor afterwards, that's fine. But that's something that they would really recommend only in cases in which there is a really high number of oocytes.
In fact, my husband had microtesy, and the specialist said to me, we've worked hard to try and retrieve sperm from him. So my suggestion would be to try and fertilize with his sperm. He actually didn't end up having any. So we moved to donor sperm anyway, but it was a conversation that I had. So I'm sure you get that question a lot. So that's really useful advice. Thank you. Thank you to everyone joining tonight. It has been an excellent conversation. I hope everyone's found it useful. Thank you so much for your time, Dr. Oliveros. Please do contact Barcelona Ivf. The contact details are there, or feel free to message me, whichever you want to do.